All right, so welcome everybody to this week's It's Worth a Shot. We are going to be covering the topic of naloxone, so the usage and also the prescribing updates. We go to the next slide. Oh, I am the next slide. That was interesting. So we just have a couple updates. We are going to do another presentation on the NHSN reporting, and looks like it's going to be on March 20th. 2 p.m. in Mountain Time, noon Alaska time, and 10 o'clock Hawaii Standard Time. And so if you would like to, please go ahead and register to join us on this, because there was a lot of follow-up from the previous webinar we did, and also the It's Worth a Shot half-hour snapshot that we had of it. So we'd really appreciate if you guys joined us. So as always, there will be an evaluation link dropped into the chat box. If you guys can complete that for us, we'd really appreciate it. And also, if there's any topics or ideas that you guys have for topics, please go ahead and drop them into chat as well. And we will continue on meeting every Wednesday. We do have a polling question this week. So Jamie, if you can go ahead and load that for us, we can get that one going. All right, is your center recommending COVID-19 vaccination upon admission? Yes or no? All right, looks like we've got a pretty strong yes turnout for this one. Give it a couple more seconds to let people continue answering. Okay. Okay, we can go ahead and end the poll. It looks like we've got 83% saying yes and 17% saying no. So that's good to hear. And now we're going to go ahead and hand it over to Jesse, who will be covering this week's influenza snapshot and COVID snapshot.
Thank you, Miranda. Good afternoon to everybody. Welcome to this week's edition of It's Worth a Shot. We'll take a quick look at the weekly influenza snapshot. Again, fantastic news as we look at the influenza positive tests reported this last reporting period ending in March 4th. We're still continuing to see that decline as an overall surveillance report. However, when we look at the regional influenza weekly report, again, just be mindful of your area and if there's increased activity in your state or region. Next slide, please. All right, as we take a look at our weekly COVID-19 snapshot, again, wonderful news. We're continuing to see a decline in new cases of COVID-19, a decline in deaths, a decline in hospitalizations, and we are seeing a little bit of movement in that vaccination rate for those receiving the updated booster dose. All right, next slide, please. Okay, well, we thought we would talk about something a little bit different than COVID this week. So I hope our audience is prepared for that. So to kick us off, I thought I'd share a little bit about naloxone and what your nursing home really needs to know as we kind of hone in on the opioid epidemic and perhaps how that may be affecting our community, but also looking at our resources within our long-term care setting. Next slide, please. So what is naloxone? Naloxone is an opioid antagonist that's used for reversing opioid overdose, and it can quickly reverse an overdose by essentially blocking the effects of the opioid. It attaches to the opioid receptor and it can reverse and block that effect. Naloxone or Narcan, it does come in two forms, and that would be either injectable or a prepackaged nasal spray. And those are both FDA approved. So again, injectable or prepackaged nasal spray. And this can help with the temporary treatment, can provide for temporary treatment that can be administered when patients show signs of opioid overdose. And really, we're looking at where research indicates that there's a great opportunity for clinicians to prescribe naloxone alongside those that may have prescription opioids to help reduce those risks of opioid-related emergency room visits and potentially overdose deaths. All right, next slide, please. So what does that mean for us? What does that mean for us in the nursing homes? Well, this is the opportunity to kind of look at a couple objectives here. So when we look at our pharmacy emergency e-kit, our e-kits in our nursing homes, does everyone know how to access them, where they are, if you have multiple, and what the content is in those e-kits? And it's important to bring this topic up, especially as we look at high level of travelers, traveling nursing staff that are in our facilities. Do you have policies that take into account that traveler, those traveling staff, as far as how do they access it? Do they have access? Maybe taking in consideration when you look at your e-kit as a whole, do you have an automated dispensing unit? So one of those OmniCells or Cubex machines, and do your traveling staff, are they granted temporary access the minute they hit the floor to get into those e-kits? Or maybe you have an external e-kit with some of those more emergent supplies. Again, what's your policy? When do you orient staff to that process? And are you making sure to capture those temporary or traveling staff so that they know how to access the e-kit? Because ultimately, that's going to be critical when you're looking at how to get a hold of that Narcan or naloxone. And also, more importantly, or maybe alongside the importance of how to access, but does your consultant pharmacist assist to provide education to your nursing team? Maybe help provide education on recognizing what an overdose looks like and how to use Narcan and basic administration procedures. So just things to keep in mind. And what form Narcan do you have? Maybe your e-kit has the nasal spray, but maybe you help out another facility that has the injectable. So again, just a good time to take a look at that e-kit. Next slide, please. So as we kind of reflect and we want to make sure that we're prepared and we're aware of our center's need for Narcan maybe and how to access it, it's important that we take a look at a few things here. You want to make sure that you are reviewing your residents' admission assessment for history of substance abuse. And this is important as we can tie that into perhaps flagging a co-prescription for Narcan, or making sure that we capture that admission drug regimen review for use of opioids. Educating all our nursing staff on assessing for signs of clinical overdose. How often do we do that? When is the last time we've done that in our nursing home? Two staff should be present through the administration of naloxone. After administration, we want to make sure that our provider is aware of the administration and the ultimate outcome or effect on that resident. And we also want to make sure that we document in medical records that individuals received Narcan, the dose, the response, and then again, continued communication outward. This ultimately, these just core elements will help us be prepared and be aware if we do have to administer Narcan. And we ask ourselves, what is your policy? Do you have an opioid stewardship policy? If you don't, what's the process looking like to develop one? And again, do you have these elements contained maybe in another policy? Next slide, please. So as we look at the medication itself, this first slide here I want to show you is the nasal form of Narcan. This nasal spray, there's a couple important things to make sure that your staff, yourself are educated on. These nasal sprays, they do not require assembly. You do not have to prime them. And as a nurse, a lot of times, you look at some of these devices and there's a natural instinct to prime things. It's very important that your staff is aware you do not prime these or you'll lose the dose. Each device only comes with one dose. Each package contains 2 single-dose devices. So essentially, you'll peel back the package and take this nasal spray out, and you can place it in either nostril and depress the red plunger and administer the medication. If you don't receive a response within 2 to 3 minutes, you have a second single-dose device on hand that you can administer. Okay. And then we do have some resources on here too that I'll share forward. And we are working on developing a competency to share out too. So you'll have something to share with your staff. Next slide, please. So as we look at the injectable form of Narcan, this form can be given IV, IM, sub-Q, and the vial that you will typically see in your e-kit is going to be a single dose vial. It's important to recognize that this is only a single dose vial. So if you were to pull this from your e-kit and administer it, do you have a second vial on hand? You may want to bring that with you. And a second vial is going to require a second needle and a second syringe. And that's kind of when we talk about, cross-referencing back to your e-kit process and policies. This is also important to be mindful of is, once a medication is pulled from your e-kit, what does the replacement process look like? And making sure that your staff is familiar with that. So if the next person goes in to pull something as urgent as Narcan, they'll have it. All right. Next slide, please. So key takeaways, really, we want to make sure that we have naloxone on hand, be aware of how to access it in the event of an overdose. We're supporting that education for our staff. The staff understand that opioids are being managed in the facility, and they understand their policies, and those policies support the process and education. Consider tapering pain and benzo medications as appropriate. Document the history of opioid use disorders and support the residents with alternate pain management strategies, keeping those care plans updated. Work with your primary pharmacy and prescribers and co-prescribe naloxone as a best practice. All right, next slide, please. So here's a few resources. I will drop them in chat. Remember to always contact your pharmacy provider for assistance as needed, and work with your prescriber as well. Next slide, please. So with that, I introduce my coworker from Alaska, Kyla. Take it away.
Thanks, Jamie. Or Jamie. Jesse. We have Jamie, our facilitator today. So I wanted to address a couple of the questions in the chat. One of them is from Katie. She said, we'd love to know who is implementing enhanced barrier precautions and how. It seems like most facilities view EBPs as strict and unrealistic to implement fully and do not contribute to the home-like environment. So I don't know if anybody has information on that. I know it's not related to our topic today, but definitely related to the COVID information that we presented earlier.
Kyla, I don't know if any of our state EPIs are on the line.
Yeah, I don't know if I saw Montana on today. We can definitely follow up on that question if we for our Q&As next week.
Yep, you bet.
Yep, and then I just put quickly in the chat, The products that you have at your facilities are most likely the products that Jesse went over, but there are two newer products on the market. The Cloxato nasal spray, which is an increased dosage of naloxone, and then the Zimhi auto injector. But most likely those being brand name products, they're probably going to be cost prohibitive. So, but just an FYI that they are out there. So I'm going to be talking about the CDC opioid prescribing guidelines, which were updated in 2022. We can go to the next slide. So the previous guidelines came out in 2016. And really when they came out, folks kind of misapplied or even over-applied some of them based on some of the kind of restrictive factors that were put into those guidelines. And the fact that they were actually only for chronic pain and not for acute and subacute pain. So these guidelines have been updated to include some additional components. And there are 12 recommendations. I'm not going to go through each recommendation specifically, but we do have a nice overview of those on our website, which I just put in chat, if you want to go through and look at each of those 12 recommendations specifically. So really the intent of these was to improve communication with patients about the benefits and risks of pain treatments, including opioid therapy, improve safety and effectiveness of pain treatment, mitigate pain, improve function and quality of life for patients with pain, and reduce the risks associated with opioid pain therapy. So those risks being opioid use disorder, overdose, and ultimately death in our worst case scenarios. We can go to the next slide. So really, like I said, the previous guidelines were not really clear on some things. And so they were misapplied in some circumstances. So it's important to note that this guide is to help inform and educate providers. And it is only for patients 18 and older. And then, as I mentioned, it's for acute, subacute, and chronic pain, and different guidance for each of these levels of pain. And then it's meant to be flexible based on really patient-specific preferences, patient-specific risks, and really looking at decisions for treating pain as a shared decision-making process with the patient or the caregiver being involved. So this is not a replacement of clinical judgment. This is not applicable to patients that have palliative care, end of life, cancer, or to replace any regulatory or FDA labeled approved indications for treatment of pain. And it doesn't give any guidance either on using opioids for opioid use disorder. We can go to the next slide. So one of the things that was new in these guidelines was these guiding principles. So basically there's 4 guiding principles to kind of support the implementation and application of these guidelines. So basically they defined 3 levels of pain based on duration of pain. So acute is less than 1 month, subacute being 1 to 3 months, and chronic pain being greater than 3 months. So previously, as I mentioned, the guidelines were only for chronic pain, but a lot of times folks were applying them to more of an acute pain situation. And so this has been clarified in these recommendations. They're voluntary and intended to support, not replace, individualized and patient-centered care, and that they need to be flexibly applied. We added, they added the kind of concept of using multimodal and multidisciplinary approach to pain management. So this is really including the whole care team, including physical health, behavioral health, long-term services and supports, and looking at the outcomes and well-being of each patient individually is really critical. And then special attention needs to be given to avoid misapplying the clinical practice guidelines beyond its intended use. And then also the other thing that they added was the addition of health equity and disparities, and looking at that as another thing to consider when we're treating patients with pain. There's new data to expand on prescription opioids for acute pain. So the review of the data shows that non-opioid therapies are at least as effective for most common types of acute pain. So including, but not limited to, and this is what we've seen in the research, low back pain, neck pain, pain related to other musculoskeletal injuries, and pain related to minor surgeries. And I will actually have a slide that kind of looks at those different therapies and how for these acute pain situations, some non-opioids are actually more effective for the treatment of pain in the acute circumstances. And then it added the non-opioid therapies that are recommended, such as Tylenol or acetaminophen, anti-inflammatory drugs, and then physical treatments like heat therapy or cold therapy, acupuncture, spinal manipulation, massage, exercise therapy, and even weight loss. And then behavioral treatments, including things like cognitive behavioral therapy and mindfulness-based stress reduction. So these are things that they included now that were not included in the past. And we can go to the next slide. So really the original, the guidelines were just focused on primary care providers. So they basically said, you know, this applies to every healthcare provider now, and just kind of clarified that more than changed it. They also said there's a delineation between patients who are getting initial opioid therapy versus ongoing opioid therapy. So the initial decisions, well, both decisions actually should be really utilizing that shared decision-making process, including the patient, letting them know the risks versus benefits of using opioid therapy. Opioid tapering was included in the last guideline, but really there was not a lot of guidance. So they've kind of clarified and given more guidance on additional aspects of opioid tapering versus just the reduced by this percentage, you know, every week or whatever, including behavioral health support during tapering, the recognition that folks may taper at different rates based on multiple factors, but one of the main ones being how long have they been on opioid therapy and what dose of opioid therapy are they on. And then it addresses challenges and then just continuing high dose opioids, and if that's really a benefit to patients, and it might be for some patients, really being able to look at those risks versus benefits for those patients. And then it also looks at considerations for dosing. So really, when you look at the evidence for initial opioids and exposure, the lowest dosage for the least amount of time, as you add on to both of those factors, the risk of having opioid use disorder, opioid dependence goes up substantially. So really keeping that in mind when you're talking to patients and making those decisions. And then, as I mentioned, those non-opioid therapies. So all the things I mentioned earlier, and really considering those, and not only just using those, but using those in a multimodal form. So you might be using opioids alongside one of those other methods to either reduce the duration of opioids or reduce the dose of opioids. And we can go to the next slide. So this is that study. It was a Cochrane review that I mentioned earlier. This looked at all of these different medications. You'll see basically your kind of typical opioids, so oxycodone, codeine, tramadol, which is considered opioid-like drug, and then comparing those to our anti-inflammatories like Celebrex or celecoxib and ibuprofen, and then also acetaminophen or Tylenol being on this chart. And as you can see, in most cases, ibuprofen or Tylenol or another anti-inflammatory like celecoxib or any of the NSAID anti-inflammatories are either more effective or equally effective. And in most cases, they're more effective. And this was specifically for acute post-op pain. So I will clarify that. But ibuprofen and acetaminophen, as you can see on the far right, were actually the most effective. So just something to keep in mind. And really, these folks, they're just doing post-op management from acute conditions, or even things like musculoskeletal pain or fractures, really can just get by on these other drugs, and they actually work just as effectively or even better in some cases. And I think that is my last slide. I have a list of resources. Mountain Pacific, as I mentioned, did put together that at a glance guide. Basically, that kind of just hones it into a 2-page kind of overview, so you don't have to go through the whole guideline, or even the CDC website has multiple pages to go to, but this is just a nice kind of 2-page overview. And then when you are prescribing opioids or looking at patients that are using opioids, there's some really nice assessment tools and screeners that are on this web page. There's a ton of them. So it's not only risk assessment for opioid use disorder, but there's some pain assessment screeners on there. And so something you might be able to utilize in your facilities. Oh, thank you, Jamie, for putting those in. So I think that's all I have. Is there questions, comments?
I don't see any, Kyla.
Okay. Yeah.
Oh, thank you. We dropped a ton of links in the chat box for you guys. And towards the top is, again, that registration link for the NHSN reporting webinar that we're doing next week on the 20th. Just, again, going over some of the troubleshooting and frequently asked questions and data entry errors that we're seeing with NHSN. So feel free to hop on that. Again, the link is in there. Also, we have the evaluation towards the top. If you have a moment, love to hear from you guys. And again, thanks for the recommendations. We'll look to see who we can bring on to talk about implementing enhanced barrier precautions in our long-term care centers. That's a great topic. So thank you guys. Thanks as always. Stay well and see you next week. Same time, same place. Thanks, everyone. Thanks, Kyla.
Bye.